Okay, let's unpack this. We're diving deep into the pharmacology of Otic drugs. The meds specifically for ear conditions.
Yeah.
Our mission today, it's pretty clinical. We want to give you the fastest route to really getting this chapter. We'll cover the essential anatomy, the common disorders, key drug classes, and maybe most importantly, the nursing safety points you really need to know for practice.
Absolutely. And that clinical context, it's everything here. Unlike a lot of drug groups we talk about, most otic drugs are topical.
Right, applied directly.
Exactly. Which means how well the treatment works and honestly how safe it is for the patient. It almost entirely comes down to your administration technique. You've got to be good at visualizing the inside of that ear, especially checking out the eardrum, before you even think about putting drops in.
And these conditions like otitis media, they're not exactly rare, are they? I saw a statistic that just, wow.
Yeah, tell me about it.
Otitis media, your classic middle ear infection, it's the second most common infection in Canadian kids. Something like 75% of them get at least one episode before they even start school.
That scale, that sheer number, is why this knowledge isn't niche. It's foundational.
Okay, so before we even think about putting meds in the ear canal, let's quickly map the territory. Can you give us that quick tour, the three main parts of the ear?
Sure thing. Let's visualize it. Think of the ear in like three sections. Section one, the outer ear.
Okay.
That's the part you see, the pinna, and then the ear canal, the external auditory meatus. That canal stops right at the tympanic membrane.
The eardrum. Got it.
Exactly, the eardrum. Section two is the middle ear. There's this air-filled space right behind the eardrum. Inside there are those three tiny little bones, the malleus, insulcus, and stapes. They transmit sound. And critically, there's the eustachian tube connecting the middle ear back to the throat, the nasopharynx, to balance pressure.
Right, that tube's important.
Very. And finally, section three, we go deeper into the inner ear. This is where the sensory reaction happens. The cochlea for hearing, and the semicircular canals, which handle our balance.
Outer, middle, inner. Okay, makes sense. Now, let's talk problems. The two main infections we treat with these drugs, otitis externa, OE, and otitis media, OM. What's the core difference there?
Okay, so otitis externa, OE, think outer, it's an infection or inflammation of the outer ear canal itself.
Like swimmer's ear.
Exactly like swimmer's ear. Often happens after swimming, obviously, or maybe some minor trauma to the canal. The good news is these usually respond really well to topical meds. Sometimes they even clear up on their own. Symptoms are usually itching, redness, maybe some swelling, drainage.
Okay, so that's the outer ear.
Yeah.
And then otitis media, OE, that's the one causing all those sleepless nights for parents.
Right, the one. OM is the middle ear infection, the pressure cooker behind the eardrum. Yeah, it's huge in pediatrics. Kids under 2 are especially prone.
Why is that?
It's their anatomy. Their eustachian tubes are just naturally shorter, narrower, and this is key, they sit more horizontally than in adults.
Ah, so drainage is harder.
Precisely. Fluid doesn't drain well, and it makes it really easy for bugs from, say, a cold or upper respiratory infection to travel right up that tube into the middle ear.
And both conditions, OE and OM, they can bring on some pretty miserable symptoms, yeah.
Pain, fever.
Oh, yeah. Pain, fever, just feeling generally unwell, that sensation of pressure or fullness in the ear, sometimes muffled hearing. And you really don't want to leave these untreated.
What are the risks there?
You're looking at potential tinnitus, that ringing sound, nausea, vertigo, even infections spreading to the mastoid bone behind the ear, and worst case, temporary or even permanent hearing loss.
Wow, okay. So that potential for serious problems, it brings us to something really important. You mentioned earlier the context of treatment, especially for OM. You said guidelines have shifted.
They really have, yeah. Given the huge concern about antibiotic resistance, recent Canadian Pediatric Society guidelines from 2016, updated again in 2022, have pushed for a pretty fundamental change in managing mild OM, particularly in kids who don't have a high fever. Wait, so hang on. We don't just automatically give antibiotics anymore. How does that work? How do you balance treating the kid's pain with, the bigger picture of antibiotic overuse?
That's exactly the tightrope we're walking now. The strategy leans much more towards initial observation.
Watching and waiting.
Kind of. It's active observation, close follow-up, and being really aggressive with pain relief. So using things like ibuprofen or acetaminophen, because a lot of these mild cases actually resolve on their own. So we try to avoid the systemic antibiotic unless it's clearly needed. Now, if the decision is made to treat with antibiotics, amoxicillin is still the first choice for kids. It just gets into that middle ear space really well.
Okay, that systemic strategy for OM is crucial context. But let's swing back to the topical treatments, maybe more for OE, the stuff we actually put in the ear canal. What's in that toolkit? You mentioned they mostly stay local, which is good for avoiding drug interactions.
Right. And the defining feature of that Otic anti-infective toolkit is the combination product. The main strategy is to pair an antibacterial or maybe an antifungal with a potent corticosteroid.
Steroids, like hydrocortisone or the dexamethasone.
Exactly those.
Why the steroid? What's it doing in there?
The steroid tackles the symptoms, the misery. It gives you powerful anti-inflammatory effects. It helps with the itch, antipruritic, and it calms down any allergic component. So you're not just fighting the bug, you're making the patient feel a whole lot better faster.
Makes sense. So we see that in common drugs like Spore HC Otic suspension, that's neomycin, polymyxin B, and hydrocortisone, and also Ciprodex, which combines ciprofloxacin and dexamethasone. Speaking of those, there's a massive safety warning here, right? Something absolutely critical.
This is probably the single most important clinical point in this whole chapter. Those combination products containing neomycin, polymyxin B, and hydrocortisone. They are strictly contraindicated if the patient has a perforated eardrum, known or even suspected.
Contraindicated. Okay. What happens if that rule is broken? What are we trying to prevent?
Permanent damage, irreversible damage. The neomycin component is an aminoglycoside antibiotic.
Okay.
And that class of drugs is infamous for potential ototoxicity, meaning it can damage the ear. If that medication gets through a hole in the eardrum and reaches the delicate structures of the inner ear.
Like the cochlea or semicircular canals.
Exactly. It can cause permanent hearing loss or serious balance problems. You're basically risking trading an ear infection for potential lifelong disability.
Hmm.
Huge deal.
That really does raise the stakes. Wow. But then you mentioned Ciprodex, the ciprofloxacin and dexamethasone combo. That one's different. I heard it can be used even if the eardrum is perforated.
And that's the crucial exception you have to know. Ciprofloxacin is a different type of antibiotic, a fluoroquinolone. It doesn't carry that same high risk of ototoxicity like the aminoglycosides do. So yes, the ciprodexamethasone combination, Ciprodex, can generally be used safely even if the eardrum's integrity isn't intact. It's a fundamental decision point in practice. You absolutely have to get that right.
Got it. What about fungal ear infections? They usually show up as otitis externa, right?
Yeah, usually OE. For fungal infections, you might see products like Locacortin Vioform, which has cleoquinol, an antifungal, and flumethasone, a steroid. Sometimes these drugs come in special bases, like polyethylene glycol, which can help soften earwax and make sure the drug stays in contact with the canal wall longer. Oh, and sometimes, for really tricky infections deep in the canal, the technique involves soaking a little cotton wick one you can easily retrieve later with the medication and placing that inside the ear canal.
Okay. Let's switch gears a bit, away from infection to more of a mechanical blockage. Earwax buildup. We need to talk about cerumen analytics, earwax softeners, basically.
Right. Cerumen or earwax, it's totally natural. It's made by modified sweat glands in the ear canal. But sometimes it builds up, gets hard, impacted.
And that causes problems.
Yeah. Pressure, pain, sometimes muffled hearing. So these emulsifiers, or cerumen analytics, they work chemically. They basically take that waxy, nonpolar stuff and help make it more water-soluble.
So it can be flushed out.
Exactly. It loosens it up so you can usually remove it with gentle irrigation, typically using warm water and maybe a little bulb syringe. Even simple things like mineral oil or olive oil can help soften it sometimes.
And the main drug we see for this is carbamide peroxide, right? Like the brand Murine. How does that one work? It seems a bit different.
Carbamide peroxide is actually pretty cool. When it gets into the ear and mixes with moisture, it slowly starts releasing hydrogen peroxide and oxygen.
Hydrogen peroxide, like the stuff for cuts.
Sort of, yeah. But the key here is the oxygen release causes this gentle effervescence, a foaming or bubbling action.
Ah, like a little scrub brush.
Kind of. It's a mechanical effect. That bubbling physically helps loosen and lift the impacted wax off the canal walls. Plus, the oxygen release gives it a little bit of a weak antibacterial effect, too, which is a nice little bonus.
Okay. And even though it sounds pretty harmless, foaming away earwax, I assume there are still safety rules.
Always.
Yeah.
Absolutely. You shouldn't use any earwax emulsifier without checking with a healthcare provider if the person has any ear drainage, if you suspect the eardrum might be ruptured, or if there's already significant pain or irritation going on.
Right. Don't want to make things worse. Okay, this brings us right to the practical side, the nursing process, because messing this up means even the right drug won't work well, or like you said, could even cause problems. What's the absolute first thing, the non-negotiable assessment step?
The absolute non-negotiable is checking the eardrum, confirming the integrity of that tympanic membrane.
Because of the neomycin risk we talked about?
Exactly. Since perforation is a strict contraindication for those neomycin products, you have to assess the eardrum before you administer those drops. You should also get a baseline sense of their hearing, and of course, check for any known allergies. Document everything.
Okay, assessment done. Now implementation. Putting the drops in. Let's hit the big ones for technique. First, the temperature rule. This seems like a huge practical tip.
It really is. It's one of those things that can make a huge difference to patient comfort. Otic solutions must be given at room temperature.
Not cold.
Definitely not cold. If you put cold drops into the ear canal, that sudden temperature change right near the inner ear structures, the semicircular canals for balance, can trigger a nasty vestibular reaction.
And that means what?
Dizziness, Raja?
Intense dizziness, sometimes vomiting. It's really unpleasant and totally avoidable. The patient might feel like they suddenly have terrible vertigo.
Yikes. Okay, so how do we warm them safely if they've been in the fridge?
Good question. You can run warm tap water over the outside of the bottle for a bit, or just take it out of the fridge about an hour before you need to give it. The key thing is never use a microwave.
Why not? Too fast. Way too inconsistent. You risk getting hot spots, overheating the medication, which could degrade the drug and make it less effective, or even potentially cause burns. Stick to gentle warming methods.
Room temp drops. Got it. Avoid the dizziness. Okay, next crucial technique point. Positioning the pinna, the outer ear. This changes based on age, right?
Correct. And it's all about straightening out the ear canal so the drops actually go down where they need to. Remember how kids' eustachian tubes are different? Well, their ear canal shape is a bit different too.
Okay, so how do we do it?
For an adult, or anyone over 3 years old, you gently pull the pinna up and back.
Up and back for adult.
Right. But for infants and children younger than 3, you pull the pinna down and back.
Down and back for little kids. Got it. That's a key difference to remember.
Absolutely essential for getting the medication delivered effectively.
Okay, drops are in, correctly warmed, ear positioned right. What happens next? Do they just jump up?
No, you need to give the medication a little time to spread and coat the canal. After you put the drops in, you can gently massage the tragus, that little bump of cartilage right in front of the ear opening.
Okay, a little massage.
Yeah, it just helps work the drops down into the canal. Then the patient needs to stay lying down on their side or sitting with their head tilted so the treated ear is facing up. Keep them like that for about 5 minutes. Let gravity help.
5 minutes. Okay. And what about patient education? Things to tell them not to do.
Oh, definitely some important warnings. You have to tell patients not to stick Q-tips or cotton swabs deep into their ear canal. Cleaning the very outer part is okay, but nothing inside.
Because it just pushes wax further in, right? Or risks injury.
Exactly. And also warn them against things like ear candling, totally ineffective and potentially dangerous, or using those oral jet irrigators designed for teeth. Those are way too forceful for the ear and can cause damage.
Good warnings. Okay, finally, evaluation. How do we know if the treatment worked?
You're looking for the obvious signs of improvement. A clear decrease in pain, less redness, less swelling. If they had a fever, that should resolve, and hopefully their hearing starts to improve if it was muffled. You also need to keep an eye out for any adverse effects, like a rash or significant local irritation. That could signal a reaction to one of the drug components.
Okay, fantastic. We have definitely covered a lot of really critical, high-stakes stuff here. So if people listening are trying to boil this down, what are the, say, 4 absolute must-remember takeaways from this deep dive, I'd say? First, know the difference between otitis media, middle ear, think stomach strategy sometimes, and otitis externa, outer canal, mostly topical. Second, remember those combo Otic drugs usually have a steroid to fight inflammation and make the patient feel better. Third, the huge safety point. Neomycin plus a perforated eardrum is a major NO because of ototoxicity. But ciprofloxacin and dexamethasone, Ciprodex is the exception. They're generally okay with perforation. And fourth, the 2 golden rules of application. Room temperature drops, no cold shocks. And position the pinna up and back for adults, down and back for kids under 3.
Excellent summary. Maybe just to connect this back to the bigger picture, think about what we discussed with the otitis media guidelines in Canada changing, moving away from automatic antibiotics because of resistance concern.
Right, that shift towards observation.
Exactly. So if the standard treatment for one of the most common childhood infections is constantly being reevaluated based on broader issues like antibiotic resistance, what does that tell you as a future healthcare professional? Even when you're focused on just giving topical drops, it suggests you constantly need to be questioning, staying updated, and thinking critically about all drug use, systemic or local. It's about that lifelong learning, isn't it?
That's a really powerful thought to end on, that need for constant vigilance and critical thinking.
Thank you for joining us for this deep dive. This has been a presentation from the Last Minute Lecture team.